The last two drugs are fairly safe. Levothyroxine does bind to surfaces, and it's best to be taken without food. With the aripiprazole, he might be at increased risk for heat stroke, so needs to be aware of taking precaution on hot days. And lastly, he needs teaching on some of the potential side effects like nausea, vomiting, and diarrhea. It would certainly be okay to take that with food. It also may increase sedation and may have a constipating effect. Just some general tips for this patient in particular. A simple written schedule might help him remember when to take pills, and maybe even a pill reminder filled by his caretaker would help him. Whatever method is used, it needs to be clear and easy to understand to meet his needs. In the last part of our case study, we would like to review at least 3 problems that were identified related to the drugs administered to this patient. After reviewing the patient's medications, there are several different possible pharmacological problems that have been identified. The first problem that comes to mind is that the patient has an INR of 1.8. The patient has a history of atrial fib and is at risk for pulmonary embolism. The recommended INR for prophylaxis and treatment of thrombotic disease is 2 to 3. The American College of Chest Physicians anti-thrombotic guidelines state that the clinician should first determine if there's a causative factor for the low INR. If there is no causative factor that can be determined, the weekly cumulative dose of warfarin is usually increased by 10 to 20%, and more frequent monitoring should be instituted until the INR is stable. The second problem that should be addressed is the patient's history of thyroid dysfunction. We know that he has a history of hypothyroidism, but we'd also want to make sure that he is not currently in a state of hyperthyroidism. There may be a need to decrease the patient's thyroid medication if that is the case. The American Heart Association states that if hyperthyroidism is the cause of atrial fibrillation, treating the thyroid condition may be enough to make the atrial fibrillation go away. Clinical recommendation is to determine if the patient has been taking thyroid as prescribed. If the answer is yes, a TSH should be checked to determine if the patient has subclinical hyperthyroidism that may be the underlying cause for the patient's arrhythmia. As we stated, we did not have a current TSH, so that would be an important piece of information to have. The last problem identified has to deal with the patient's antiarrhythmic medication, which includes several possible problems that may need to be addressed. Although amiodarone is considered to be an effective antiarrhythmic, there are several possible problems that may result from its use. Katzung et al. States that abnormal liver function tests and hypersensitivity hepatitis may develop during amiodarone treatment, and liver function tests should be monitored regularly. Referring to the previous slide, Katzung also goes on to state that amiodarone may result in hypothyroidism or hyperthyroidism. Thyroid function should be evaluated before initiating treatment and should be monitored periodically. Considering that the patient is taking thyroid medication, this is very important. Additionally, Katzung states that amiodarone effects on organ systems and amiodarone treatment should be reevaluated whenever new symptoms develop in a patient, including arrhythmia aggravation. And finally, on the topic of amiodarone, again, we talked earlier about how it inhibits several cytochrome P450 enzymes and may result in high levels of many drugs, including warfarin. One possible solution to consider would be changing the amiodarone to another antiarrhythmic. This concludes our case study. Please find the listing of our references for your review. Thank you for the opportunity to present our case study.